Well, thank you very much. I hope you remember a little bit from the first lecture, which was a little bit kind of dry. This one has a lot more science, and probably this is the one where you'll be thinking a lot more than simple non-malignant pleural effusions like CHF or parachyrothorax. So I'm going to focus on parapneumonic effusions, which is the biggest category. But what I'm also going to do is try to touch on some of the areas of, I wouldn't say controversy all the time, but things that sometimes confuse us in managing parapneumonic effusions like thoracentesis, chest tubes, what size of chest tube, intrapleural fibrinolytics is sort of a new topic which is somewhat controversial. So we'll talk a little bit about that as well. So these slides you've seen before. The pleural anatomy, it's derived from the embryonic mesoderm. You have the visceral pleura and the parietal pleura. Has a pretty large surface area, about 2,000 centimeters square. And the two layers are joined at the pulmonary ligament. You've seen this before. So they have their blood supply from different circulations, parietal pleura from the intercostal and visceral pleura from the bronchial circulation. This is just a micrograph of the pleura. It's a pretty thin wall structure. You have the mesothelial cells sitting on a basal lamina, and then there are two layers of elastic lamina, the superficial and deep, with a little bit of connective tissue in between, where you have the veins and the lymphatics, and then you've got the long parenchyma underneath. I think you've seen this before. The normal pleural fluid is an ultrafiltrate of the pleural of the pulmonary circulation, gets into the pulmonary interstitium and then squeezes through between the visceral pleura to enter the pleural space. And then the parietal pleura has these parietal pleura stomas, which is about 2 to 6 microns, and they expand and contract with breathing, and they swallow that pleural fluid into the circulation, lymphatic circulation. So normal pleural fluid, it's very low volume, it's clear, low in protein, and most of the protein is albumin. It's low in cells. Most of the cells are monocyte macrophage. What's important to know is that there are very few neutrophils and no eosinophils in normal pleural fluid. Normally it's alkaline, its glucose is the same as the plasma, it has very low LDH, and the rate of absorption of pleural fluid is several-fold more than the rate of production. So when and if patients develop significant pleural effusion, that means that there's a severe discrepancy and pleural fluid formation has to increase by about 30 times the normal in order for patients to start having an infusion. And normally the pleural fluid absorption is the function of the parietal pleura, as we saw those little stomas on the parietal pleura. Pleural manometry, you'll probably see it being done more at the VA. We do it every now and then, especially in patients with what looks like large, chronic, somewhat loculated pleural effusions. What is a normal pleural pressure? It's somewhat of a difficult topic to discuss. It's not very well understood because the space is so small that if you put a pressure transducer in it, just by putting a pressure transducer, you can change pressure. So that's why these phenomena are not very well understood. But we know that the normal pleural pressure is about -3 to -5. Now, look at this number here. So there's one study where they found that if you took out 1 liter of pleural fluid and then you checked spirometry afterwards, patients' FEV1 and FVC was increased by about 200 cc's. Why is that important? Because we know that a liter of pleural fluid is going to cause a lot of dyspnea. That's for sure. And traditionally, it's thought that dyspnea in pleural effusion is because it compresses the lung, doesn't let the lung expand. But this one sentence will actually go against that kind of a thinking. Why? Because even after removing 1 liter of fluid, you increased patients' FEV1 by about 200 cc's, which really isn't much for patients to feel a significant improvement in dyspnea. So that means that there are many other mechanisms other than just the lung not expanding. And we think that the biggest mechanism for patients having dyspnea with pleural effusion is that their diaphragm doesn't move well because they're already pushed down, in addition to neurogenic mechanisms. We is trying to reach to us. This is Earth. So the other reason why pleural manometry can be good is because if you have a lot of pleural fluid and you want to remove almost all of it, you can use pleural manometry, and if the patient's pleural pressures stay above -20, technically you can remove it. There was a patient just last week at the VA with a very large, complicated pleural effusion, and we did pleural manometry, and his pressure stayed about 0 to 2, and we were able to remove about 2.5 liters. Towards the end of it, it dropped down, so we stopped right there. So pleural manometry can help you to remove a lot of fluid in one setting, can also identify patients who are going to have trapped lung, so you don't waste time in trying to do pieces. You can just go with pleural catheters or just consult the surgeons. What do I mean by a trapped lung? So this is pleural space elastance, which is change in pressure over unit change in volume. So as you, in a normal lung, say hepatic hydrothorax, where there's not a lot of protein, there's not a lot of scarring from the pleura, as you are removing pleural fluid, the lung is expanding, and so the pressures in the pleural space stay about the same. So this is a lung which should expand fairly normally. Then you have a condition called entrapped lung, which is usually seen in acute inflammatory conditions, where as you remove fluid, initially the pressures will drop, but not so much, but towards the end they will drop a lot more. That's an entrapped lung, where you have an inflammatory process, and so it retards the expansion of the lung. And then you have a condition called the trapped lung, which is a more advanced condition, where there's actually almost a fibrous scar on the lung. So the lung either does not expand at all or expands very late. And so these patients will have a very sharp drop in their pleural pressures. Sometimes you'll have severe chest pain where you have to stop pleural drainage. And on X-ray, sometimes you will have what looks like a pneumothorax. But it's actually not a pneumothorax. It's just what's called a pneumothorax ex vacuo, which means that you took the air out or took the fluid out, and what's left is just air, and the lung is not expanding, so it's just stuck in one position. So that's a situation where you don't need to put a chest tube immediately, even though you'll get called by the radiologist that there's a pneumothorax, but just understand that this is actually a trapped lung. What's happening?
Hi, you guys were having audio issues?
I don't know, somebody was trying to reach out to us from the VA.
Oh, they can't hear you at the VA.
Well, no, there's a lot of background noise. It's fine.
Oh, okay. I say that is a Tim problem. Unfortunately, it's not mine.
Okay, well,
Then we do.
I think it's better now.
Okay.
All right, so this is just a little bit of background. So we're going to talk about parapneumonic effusions, which is a big category of non-malignant effusions. Like I said, this is the one situation where you have to do things somewhat immediately, and oftentimes the management, especially long-term management, is not that straightforward because of all the different interventions that we have available. So what is parapneumonic effusions? About 80,000 cases are seen each year, combined in the US and UK. Around about 50% of the pneumonias will develop some degree of parapneumonic effusion, and about 15% of the pneumonias will have a complicated parapneumonic effusion. We'll go through what these terms mean. And then empyema, which is presence of gross pus in the pleural space, will be seen in about 5% of the patients, but has a high mortality, about 20%. And empyema, or parapneumonic effusions, generally go through 3 overlapping phases. You have an exudative phase in the first 72 hours where there's pouring of a protein-rich fluid into the pleural space, not a whole lot of cells. Then the cells start to come in the next 3 to 10 days, and then if you let the process go on, the whole pleural space becomes fibrosed, so patients end up having a fibrothorax. So here's an example of a parapneumonic effusion. So what test will you send on this fluid to confirm that this is empyema?
Cell count differential.
Cell count differential. I always hear it. What else? pH. Gram stain. So which one of these will confirm that this is an empyema? This is a very important question. pH. So the question is, the answer is none of the above. And the answer is given right here. The presence of pus in the pleural space is empyema. We don't care what the pH is. We don't care what the cell count is. We don't care what the LDH is. We don't care what the glucose. All those help us manage empyemas, but they don't confirm or diagnose empyema. So that's an important issue. So if you get, say, only 10 cc's of fluid that looks like this, don't waste it in sending for an LDH and glucose and all that. Just the culture is probably the most important because it will help you determine the antibiotic therapy. But you've diagnosed empyema the moment something like this comes out of the chest. That's it. What's the microbiology of empyema? You have to have some idea whether this pneumonia, because empyema or parapneumonic effusion in general, is it associated with a hospital-acquired pneumonia or a community-acquired pneumonia? So community-acquired pneumonias and the parapneumonic effusions associated with those pneumonias are usually gram-positive, most commonly streptococcus and staph, and then gram-negatives, and then a host of anaerobic organisms. In the hospital-acquired setting, the staph is more common, followed by gram-negative. So just keep this in mind that if somebody comes from the community, it's usually gram-positive. Just keep in mind gram-negatives and anaerobes are also possible, but gram-positives are the biggest category. In the hospital setting, you have to cover MRSA, you have to cover gram-negative rods. Another important point, there are studies that have shown that when you do a thoracentesis, you can send fluid for culture in those little clear vials that come in the kit. But if you inoculate a little bit of fluid in a culture bottle, a set of culture bottles, and send it with those tubes, it increases sensitivity. So just grab a set of culture bottles and send a little bit of fluid in the culture bottles as well. We all know Light's criteria. It refuses to go away because there are all these studies, from 1972 all the way to 96 that have looked at the sensitivity, the specificity, accuracy, positive, negative predictive value, and Light's criteria stands its ground. So it's still your best test to determine exudate versus transudate. But obviously, if you get something like this, then, it's not a question of exudate versus transudate. It's a question of what's causing it in terms of microbiology. And then you want to look at pH, LDH, those things, because that can determine if it's a complicated or simple and how aggressive you want to be. And because Dr. Light's criteria has stood the test of time, he took the liberty to come up with his own classification of parapneumonic effusions, which you can see is pretty cumbersome. From class 1 to class 7, going from non-significant to typical to borderline to simple, complex, simple empyema, complex empyema, and all these take into account 3 or 4 main features of the effusion. How much the effusion is on X-ray, what is the pH, what is the glucose, what is the LDH, what is the culture result. So a combination, different permutations of all 4 factors will give you these, one of these categories. But Dr. Light himself acknowledged that this is a very cumbersome, somewhat impractical, way to approach parapneumonic effusion. So this is usually sometimes used in research to enroll patients in research, but really from a practical clinical standpoint, this is not really helpful. So what's helpful from a clinical standpoint, there are 2 main classifications out there for parapneumonic effusions. One is the ACCP classification, and the other is the British Thoracic Society classification. So the ACCP classification goes into 4 stages, stage 1, 2, 3, and 4. And again, they are based on 3 different categories of the effusion, or 3 different aspects of the effusion. One is the amount of pleural effusion on your chest imaging, particularly chest CT. The second is your bacteriology, whether the cultures and gram stains are positive or negative. And the third is your chemistries, particularly your pH and glucose. So the American ACCP, the American College of Chest Physicians, they don't really go much into using LDH for classification. The British Thoracic Society, which we'll see later, actually puts LDH into the classification as well. So if you have a very small amount of fluid, less than 10 millimeters on lateral decube film, and your cultures are negative or unknown, pH is unknown, meaning you haven't really done a thoracentesis because it's so small in amount, then it's a simple or uncomplicated parapneumonic effusion. You don't really need to do thoracentesis, you don't need to put a chest tube or anything. Stage 2 is when you have a little bit more pleural fluid, more than 10 millimeters or 1/2 of the hemithorax. and your cultures are negative, and your pH is good, above 7.2, and your glucose is high. In this case, you need to do a thoracentesis because that's how you're going to know this. But other than that, you just don't need much. Obviously, you need antibiotics, but you don't need a chest tube. You don't need any kind of decortication. And this is where things get a little bit more complicated. Stage 3 is complicated parapneumonic effusions, where you have a lot more fluid, more than 1/2 of the hemithorax. There are lots of loculations, or the parietal pleura is thickened, or you have positive cultures, or your pH is more acidic, your glucose is low. In this situation, you obviously need to do a thoracentesis to know all this, but you may also need some way of pleural drainage, and we will go through what are the different ways of draining the pleural space. And then empyema, like I said, you don't need anything to diagnose an empyema. You just need the presence of gross pus in the pleural space. Everything else is secondary. So this is your ACCP classification. The British make it a little bit simpler. They just go into simple, complicated, and empyema. So again, they take the same features into account, which is your amount of fluid, and then the microbacteriology, and also the chemistries. So if your pH is above 7.2, LDH is low, glucose is high, and cultures are negative, then this is simple. Usually resolved with antibiotics. But if the effusion is very large in amount, then you may need to drain it. If it becomes a little bit turbid, or it becomes more acidic with a high LDH, with a high glucose, and cultures are positive, then you need chest tube drainage. And then empyema obviously requires much more complicated intervention. So which one of these is better, ACCP or BTS? The question is one study compared both of them. They're basically the same. So you can use any one of those, and the patients will generally do the same. Their sensitivity, 98% versus 97%, specificity, BTS guidelines, probably a little bit lower, but not much. And then likelihood ratios are also the same. So it doesn't really matter. It depends on what you're comfortable with. But just keep in mind that when you're evaluating parapneumonic effusions, the things you want to look at is how much the amount of the fluid is, what is the pleural space looking like? Is it simple or is it complicated, loculated? And then your studies on thoracentesis, your pH, your LDH, your glucose, and microbiology. So which effusion will this be? Simple, complicated, or something else? It's important to know, because what if this patient comes at 1 o'clock in the morning, where you don't have fellows or attendings around, and you want to make sure that there's nothing special that needs to be done other than maybe a thoracentesis. So this is a relatively this is not loculated. Why? Because it's sitting it's sitting as fluid should sit on a patient who's in supine position. You've got the lung that's compressed underneath, and it's a fairly large effusion. So if we use this criteria over here, which one of these, just say, let's just forget about this because we haven't done a thoracentesis. So which one of these will it fit in? So probably about 1/2 of the hemithorax, right?
It doesn't go exactly half, so it's less than that.
Maybe a 2. Yeah, I think it's probably half. I mean, it's probably about 2/3 of the hemithorax. What about this one? It's hard to see here, but you can actually see this is the pleura right here. So is this a loculated effusion or a simple effusion? It's a loculated effusion, right? Why? Because it's defying the laws of physics, right? Because fluid should sit as gravity wants it to sit, but it's tracking along the chest wall right here. And then you've got a pocket right here. It's again a little difficult to see, but you can see the difference in attenuation. So if at any time you see something like this where fluid is not really sitting how it should sit based on gravity, it's a loculated effusion. And if you put an ultrasound here or over here in this pocket, you may actually see a lot more delicate striations than what the CT can show you. So this is probably a complex loculated parapneumonic effusion. So this is your basic algorithm. Nothing special about it. You already know all this. This is based on the British Thoracic Society guidelines. So you have a patient with a pleural effusion in the setting of what looks like pneumonia. You do your basic clinical assessment. You look at the chest imaging. You do an ultrasound. You try to tap it. If you can't tap it because it's so loculated, you can consider CT-guided taps or ask IR to do it, which is easy to know. But if you tap it and it's not purulent, grossly purulent, meaning it doesn't look like empyema, then you run your basic chemistries and you look at what the chemistries are. You should have an idea which category of parapneumonic effusion is falling into. And if it's a simpler process, your pH is high, your glucose is high, your LDH is high, then you can continue to treat clinically until the patients show whether they're getting better or not. But if it's a complicated process, meaning it's either pus or they are very acidic on their pH, their LDH is very high, their glucose is very low, their cultures are positive, then you need pleural drainage. So you have to put either a chest tube or go to other forms of pleural drainage. This is an important point. This is probably the most important thing you can get from this slide, is that we will see down the, in the later part of the presentation that early aggressive therapy of parapneumonic effusions is very important. And early aggressive, British Thoracic Society says 5 to 7 days. Again, it's somewhat of an arbitrary limit, but we shouldn't wait several days if the patients are not showing clinical improvement. So we should get more aggressive in treating, meaning we should consult the surgeons or confirm if our chest tube is in the right position, or do other things like fluoroscopy or intrapleural fibrinolytics, which we'll talk about. So I would say about 3 to 5 days is that period where you should get a sense of whether your initial therapy, antibiotics plus minus chest tube placement, is, improving the patient or not. And if it's not, then you should go ahead and consult the specialist. What is the antibiotic therapy? If you don't know the microbiology, you probably get an idea. Start with broad spectrum antibiotics. For community-acquired infections, you can use a third-generation cephalosporin or things like augmentin for oral therapy. And then for hospital-acquired, you have to cover MRSA, you have to cover gram-negative rods. Some of the things that are important here, the anaerobes almost never grow in empyema or a complicated pleural effusion, but we almost assume that they're there. So whatever therapy you choose, make sure that you cover the above the diaphragm anaerobes. And the above the diaphragm anaerobes are different than the ones below the diaphragm. So the above the diaphragm anaerobes are usually pretty sensitive to beta-lactam. So keep an eye for anaerobic coverage. Macrolides by themselves have no role in treatment of parapneumonic effusions, and also aminoglycosides have no role because they're charged molecules, so they don't really penetrate well. Duration of therapy, nobody knows how long to treat a pneumonia that has an effusion with it, but generally we treat longer than pneumonias that don't have an effusion. And again, it's somewhat anecdotal, but generally about 2 to 4 weeks. Okay, let's talk about pleural drainage. This is where we have a lot of science. So there are so many ways to drain the pleural space. So when we say pleural drainage, you have to, have an idea of what we're talking about. So you can drain the pleural space using thoracentesis. You can put a pigtail catheter, or IR can put a pigtail catheter. In the same category, we have things like pleural catheters, like Pleurex aspera, that are generally not used for non-malignant effusions, mainly used for malignant effusion, but you can, find cases where they may be helpful. You have different kinds of small bore chest tubes, which are now available here and at Jewish. They are usually placed using a Seldinger technique, very comfortable for the patient, very easy to place for the operator. You have traditional large bore chest tubes of different sizes, which the surgeons generally prefer. And then you have some more sophisticated ways to drain the pleural space. This is a flexi-rigid pleuroscope. It's basically like a small bronchoscope that we can, as interventional pulmonologists, we do this procedure where we can do it under conscious sedation. So it's a very minimally invasive and a very safe procedure where we can go in, break down simple adhesions, drain the fluid, put a catheter in. Then you have what the surgeons do. This is VATS, and you have open thoracotomies. So these are all different ways to drain the pleural space. And thank God that we have all this, because this is what it used to be. What is this? It's not a shark bite. This is what was called open thoracotomy, or this used to be called a Clerget window, which was basically back in the olden days, if somebody had bad pleural infection, the surgeon would go in, make this huge big gash, and then turn the skin on top of the incision to basically make a pleurocutaneous fistula. So these patients will be continuously draining fluid from here, and they'll put a little, some kind of colostomy or whatever bag, and this will go in. So this is what it used to be, and this is what we have now. So be thankful. What are the indicators for poor prognosis in parapneumonic effusion? There's not much science behind it. I think as clinicians who deal with these patients, we have an idea which patient's going to do worse. And all these things, I think you already know. Obviously, if there's gross pus, the cultures are positive, the glucose is low, pH is low, LDH is high, or you have a loculated effusion. So if it looks bad, it's going to act bad. All right. Let me talk about some of the high yield points when we are dealing with pleural effusion in general, particularly parapneumonic effusions, because this is where you can actually get a lot of important information. Thoracentesis, one of those procedures that we all like to do, and we think it's pretty safe because I think it is, but there are certain important points to know here. There are not that many contraindications to thoracentesis. Unless somebody has skin infection, you can't find a spot, that's pretty obvious. Or if it's such a small effusion, less than 10 millimeters, where you feel like there are chances of damaging the underlying lung. Other than that, there are not that many contraindications. What about coagulopathy? Sometimes I hear the residents or even the fellows talking about giving FFP because somebody's INR is 1.7, or their platelets are low, or their creatinine is high. It's a controversial issue. It's a fairly safe procedure, and the risk of bleeding is very low. And so no one really knows if there's any value in correcting these abnormalities before doing a thoracentesis. One study that looked at about 1,000 thoracentesis cases, they found really there was no complication even with an abnormal INR and platelets. And another study of about 1,000 patients, they found that even with an INR of 1.6 or above and low platelets, there was very little complication rate. And even interventional radiologists think it's a safe procedure. So you should be very brave in doing thoracentesis. INR more than 2, PTT, there's no consensus, platelets less than 50. So aspirin, they can continue, but Plavix, so if somebody's on Plavix and you do a thoracentesis, they're probably going to do okay. But if you end up injuring the underlying lung, or you injure the intercostal vessel and they are on Plavix, then it can be difficult. So if possible, just stop Plavix for 5 days, but the rest of the problems are not worth noticing. Okay, this is where it gets interesting. Remember how in medical school we were taught that the neurovascular bundle travels along the inferior margin of the ribs, and so you should always go above the rib. Remember we were all taught this? Well, I hate to tell you that that's not always right. In fact, most of the time it's not right. So there are these two studies. One was a cadaveric study, one was a CT study. So this is a cadaveric study where they looked at, okay, where does the neurovascular bundle actually go in these patients? And what they found, so these are the three patterns. Linear, this is curved, meaning this is the side of the spine, so it's coming from the spine and then going laterally. And then just imagine that the spine is right here running like this, and then that's the lateral, like the flanks. And then you have this wavy and then the sinusoidal pattern. And so look at these percentages. If you add up 35%, 39%, 17%, most of them are like this. This is the one we were taught in medical school, right? It's only 7%. So they found that actually the neurovascular bundle for most of the intercostal space does not travel along the inferior margin. It actually is only along the inferior margins in the flanks, on the sides. So that's really the safest spot to do a thoracentesis. Back here where we do most of the thoracentesis, it can be just about anywhere. You can see over here, this is a intercostal vessel. This is the spine. It's coming like this and then coming to the front. And in older patients, because their muscles are weak, so their intercostal spaces become narrow, and then the vessels are a lot more tortuous. So this is where we do most of our thoracentesis, in the back. So it can be just about anywhere. So just be mindful of that. I hate to tell you that your teachers are wrong, but try doing thoracentesis now. But this is really, the lateral part is the safest. So if patients are on the ventilator, you can probably just get a good window here and go in, and this is where we put our chest tube, this is where we put our pleural catheter, so it's actually a pretty safe spot. Why is ultrasound important? Well, we know it can tell us where the fluid is, what it looks like, help us guide our intervention. It has been shown to reduce the risk of pneumothorax in 2 studies, 0% versus 29%. This was probably first-year residents. 3% versus 18%. That's still pretty high. And this reduction was seen even if you were doing a large effusion versus small, you were doing the diagnostic versus therapeutic, you had a dry tap or near dry tap, didn't matter. So ultrasound helped. It's easy, it's low risk, in fact has no risk, so use it. Even if patients develop pneumothorax after an ultrasound, less patients required a chest tube because the pneumothorax was small. However, these studies were done with real-time ultrasound. So you're looking at the fluid as you're going in. Most of the time what we do is we just do the ultrasound and then get an idea and go in. So it's not really based on studies. However, if the patients don't change their position, if you do it right there, patients are in the same position, that's still pretty good. Because it used to be so that you would call IR, they would come in, and next day you round, there's an X on the patient's back. And that's your spot. You have no idea which position the patient was on. That's not the right way to do it. This is another scary slide. So they looked at what happens if you do a clinical assessment, this is where the fluid is, and then you go in with a needle and you don't get anything. So they found that in about 90% of these kinds of situations, if you did an ultrasound subsequently, it helped you do this thoracentesis. But what's even scarier is that about 60% of the so-called dry taps, where you did your, whatever you do, and then you said, oh, this is a good spot, let's go in, and then you went in and there was nothing. 60% of those, you were below the diaphragm. That's scary, isn't it? There's some important structures below the diaphragm. And ultrasound increased the site selection by 26%, and potentially dangerous needle insertions were decreased by 10%. So what am I trying to say? I'm trying to say use ultrasound when you have it. Don't be too macho. It's going to reduce the risk of complications, and even if the patients get complications, there will be less. What else can ultrasound offer? Well, this study looked at whether ultrasound can also help us determine how to approach these patients other than just thoracentesis. So 163 patients, they looked at the pleural space with ultrasound, and these are the 4 representative pictures, and they characterized them as septated effusion. This is an anechoic, homogeneously anechoic. This is with homogeneously echogenic, and this is complex internal echoes. So based on these, they found that if you characterize these effusions and look at different outcomes as hospital stay, duration before diagnosis, how long they had the chest tube, did they require surgical intervention or fibrinolytic therapy, they found that by using ultrasound and looking at the pleural space and having this kind of a characterization, it can help you determine which patients are going to need fibrinolytic therapy, which patients are going to need surgery. So when the patients come in with a parapneumonic effusion and you look at it and you see something like this, it means you're going to have to be aggressive. Or even something like this where the fluid normally should be completely anechoic, but you have a lot of echogenic material. So it can help you determine which patients are not going to do well. There's another study, actually many studies that have looked at whether it can help us determine the size of the chest tube. So if it's homogeneously anechoic like this one, a simple small bore chest tube will be enough, 92% success. If it's a little bit septated, then you have to have a small bore chest tube, which will be enough, but the success rate is a little low. And then if you have complex septated effusion, or it's very echogenic, then you probably need either a large bore chest tube plus minus fibrinolytic therapy plus minus VATS or medical thoracoscopy. So ultrasound can help. What size of the chest tube is good? Nobody knows. There's a lot of controversy, and obviously if you call a surgeon, you put a little chest tube in, patient's not better on day 2, you call the surgeons. What are they going to do? They're going to pull the small chest tube out, put the garden hose in, right? Well, there's really no data, or I should say there's good data that a large bore chest tube really does not offer anything above and beyond a small bore chest tube. What do you call a small bore chest tube? Generally 14 French or smaller is considered small bore, or actually 24 or smaller. But generally we put the 14 French because those Seldinger technique chest tubes are usually in the 14 French range. So anywhere from 14 French to 20 French is small bore. For most situations, it's good enough, except maybe hemothorax, which is usually a surgical issue. In those situations, you have to have a bigger chest tube because that blood can clot and can block your chest tube. What is important is that it's really the position of the chest tube which is important, and not so much the size of the chest tube. So even if you have a small bore chest tube and it's in the right position, in the right pocket, that's good. Most of the time when the chest tubes are quote unquote not working, it's because they're not in the right position, not because the chest tube is small. We generally remove chest tubes when their drainage is less than 50 cc's. Small bore chest tubes may require you to flush them with normal saline, about 30 cc's every 6 hours. This is what the British Thoracic Society recommends. This was a trial done, missed one trial where they looked at all different sizes of chest tube, less than 10 French, 10 to 14, 15 to 20, more than 20, which is the category of the surgeons, and they looked at many different outcomes: death at 1 year, rate of surgery, hospital stay, your airflows, your improvement in chest x-ray, and overall there was no difference in the chest tube size. All right, few words about the fibrinolytic therapy. This is one of those things that is becoming very popular. Some of our fellows are very fond of putting fibrinolytics in the pleura. This is again one of those topics that is very controversial. There are studies really going back into the 70s. And people have tried all different kinds of fibrinolytics, streptokinase, urokinase in different doses, different regimens, and they have looked at many different outcomes. Does your chest x-ray improve? Do your symptoms improve? Do you need surgery or not? Does your chest tube come out early? Do you stay in the hospital less? Mortality. And the data is all over the place. As you can see, some studies have shown that your referral to surgery is decreased. Others have shown that there is no significant difference. Mortality continues to be unchanged with all different regimens, with all different kinds of chest tubes. And then most recently, this trial, MIS2 trial, was done. This is the MIS2 trial published in New England Journal of Medicine 2011. What they did was, instead of using urokinase or TPA or streptokinase, they used a combination of TPA plus DNase. And the idea was that we don't want to just break down the adhesions, we also want to dissolve it so they can come out easily. And so what they found was, in the 3 arms, if you combine TPA with DNase, your chest x-ray improved much more than the other arms. You required surgery much less, and you stayed in the hospital much less. So this has more or less become the standard of care when it comes to intrapleural fibrinolytic therapy. 10 milligrams of TPA, 5 milligrams of DNase given twice a day times 3 days. And then Cochrane also did a meta-analysis looking at 7 randomized control trials, which included the MIS1 trial and MIS2 trials. And they also found more or less the same results, that your mortality doesn't improve, but you require surgery less, maybe stay in the hospital less, maybe your x-ray improves. And then a more recent trial in 2014, they did a meta-analysis of 10 trials that included about 1,000 patients. Again, same results, that you needed surgery less, stayed in the hospital less, chest tube came out earlier. So at this point, as of 2015, we know that intrapleural fibrinolytic therapy is helpful. It can get patients out of the hospital, can get their chest tubes out. They may need surgery less. But where exactly does it fit in the algorithm? Should we do it early? Should we do it late? Nobody really knows. And this kind of summarizes where we stand. And the person, one of the authors on this paper was the lead author of the MIS2 trial, the TPA and DNase trial. And they say what most of us think, that it does have a role, but it should not replace your surgical therapy. If someone is fit, you have a 20-something-year-old with a complicated parapneumonic effusion, don't try a TPA. Just send for the surgeons. If he can undergo VATS and decortication, that's probably best. Some people are fond of just using large bore chest tubes and delaying surgery or not considering surgery. There's this one study that randomized patients to a large bore chest tube versus VATS, 35 patients in each. And again, they found that VATS actually did better. Success rate was 90% versus 63%, and they stayed in the hospital less. Well, what if I put a large bore chest tube and then put fibrinolytics? Again, this is an older study. They did not use the TPA plus DNase. They just did streptokinase. But again, they found that compared to VATS, a large bore chest tube plus streptokinase actually did not perform well. VATS was much better. Patients were discharged earlier, and it actually cost less. So $16,000 versus $24,000, at least back in 97, because patients were discharged early. So the whole idea is if patients are good surgical candidates and you are dealing with a complicated parapneumonic effusion or an empyema or a relatively simpler parapneumonic effusion, but they are not better at day 3, day 4, day 5, don't fool around. Just call the surgeons. I think the best thing for them to have is VATS decortication. If they refuse, if they're not good surgical candidates, then we can consider intrapleural fibrinolytics. Pleuroscopy, like I said, has some role in parapneumonic effusion. That's where we come in as interventional pulmonologists. It's still not the standard of care. Still, if patients require intervention, it's probably surgery is better. But there are 2 retrospective studies looking at about 127 patients and 41 patients, where even patients with multiloculated effusions, complicated empyemas, when they underwent pleuroscopy, which is much less invasive, much less risky than VATS, they did fine. So if you have a patient who does not want VATS or is not fit for VATS, it's okay for you to call us. Maybe we can do pleuroscopy. So just to summarize everything, early aggressive treatment of empyemas or parapneumonic effusion is most important. What is early? Day 3, day 4, day 5, just round about that time. Small bore chest tubes work just as well as large bore chest tubes or just about anything. Maybe if you have a hemothorax, then large bore chest tubes are better. Small bore chest tubes, if they get clogged or you're worried about them getting clogged, you can instill normal saline 30 cc's every 6 hours just to keep them flush. The position of the chest tube is a lot more important than the size of the chest tube. And that's why in that algorithm, the British Thoracic Society guideline algorithm, one of the points that they make is that if by day 3, day 4, day 5 after a chest tube, patients are not getting better, you can either do a CT or do an ultrasound to see if your chest tube is in the right position. Thoracic ultrasound, we talked about all the good things about thoracic ultrasound, so always use it. And then indwelling pleural catheters like Pleurix has some role in parapneumonic effusions, but we generally avoid it because it can cause infection of the tract. For other kinds of non-malignant effusions like CHF and parachydothorax, I think we went through those slides last time. There's some data that they're helpful. And then pleuroscopy for patients who are not improving and do not want surgery or are not fit for surgery is an option that is still being explored. So I think that's about it for parapneumonic effusions. I think I started late, but I finished on time.